like that. I like that background with that DNA on it. It's a nice background on that slide, don't you think?
Mm-hmm. Yeah, that is nice.
So we're quickly gathering people here. There's more. But you might want to just mute your You might want to mute your. It's live, Jerry. It's live now, so you can mute your. You can mute. You got.
That's all right. I'm not saying anything bad anyway. Good morning.
Okay, good morning. You can. I just said you could, if you wanted to, you could mute it. Doesn't matter. You are officially live.
Somebody tell me when to start.
It's 2 minutes till 8 right now, so I think Dr. Connolly might.
I can show them pictures of my grandchildren.
Use this time to show them off.
Those are the first boys I did gene therapy on with Duchenne. I love that picture.
That's so cool.
That being done or what?
I'm gonna ask. I'm not sure. Would be helpful.
No kidding. Using your valuable time. Signal to start. Good morning. I appreciate the opportunity to present what you might consider a review of 20 years of gene therapy with lessons that we learned every step of the way. These are my disclosures. And I thought that it's interesting to look at what a new field this is. The first gene therapy that was ever approved for clinical use was really a short time ago in 1990 for ADA, severe combined immunodeficiency disease. And the results of that trial were first reported in 1995. In 1999, I got my feet wet with the first gene therapy trial that had ever been done for neuromuscular disease with adeno-associated virus. And unfortunately, we didn't finish that trial because right at the same time, as I'll discuss in a minute, we had an unfortunate death in gene therapy that was due to adenovirus and not adeno-associated virus. Sometimes those are confused. And then shortly after that, I came to children's full time. And for the next really 16 years since I've been here, we've had 2 gene therapy trials that have been approved for commercial use. One was for retinitis pigmentosa, and the other was our SMA trial. And the SMA trial was approved for commercial use in 2019. And in that regard, was the first systemic gene therapy that was ever approved for clinical use. So let's just look at what we were faced with when I got into this field. On the top, I thought it would be useful to show what a gene looks like. We call it a cassette. It has a promoter, an intron. The cDNA is the gene itself, and then it has a poly-A tail. And when I first got into the field, I was told there were too many obstacles to ever make this a success. We could have promoter shut off, and you can see where the promoter is. We could have immunoblock because patients had previously been exposed to the virus. And if the virus did get in, it would cause an inflammatory process. There was also the concern about what's called insertional mutagenesis. And I'll mention this again on another slide. This would be a random DNA insertion into the human genome at a site that was not targeted. And then the ultimate obstacle was that there wouldn't be enough virus that was produced to do any systemic gene therapy. So these were things we were faced with when I came to Children's full time. Now, the choice of virus for gene delivery really came down to basically 2 initially, retrovirus or lentivirus. And the advantage of that was that it was very large, could hold almost any gene that in the human body or in the human genome, and it wouldn't be any problem in gene delivery. However, retroviruses insert into the patient's genome, and that's the problem. Adenovirus is the next choice. And the problem with adenovirus, it's also very large, not large enough to hold every gene, but most of them. But it does itself cause a human disease, and we'll see in a minute that was the problem. Adeno-associated virus is a small virus, and it was put kind of on the back burner from the day of conceptualization of gene therapy. Well, most of these problems that I mentioned, a lot of them, or most of them actually came true. Insertional mutagenesis was really the biggest fear. I was told multiple times that if you put the gene in, it could go anywhere, and that would be a problem. And indeed, in X-linked severe combined immunodeficiency disease, using the gene and put in bone marrow precursor cells with a retrovirus vector, 9 of the 10 patients were treated successfully, but 4 of the 9 developed T-cell leukemia anywhere from 31 to 68 months after gene therapy. And so this put a hiatus on retrovirus, except mostly for treating cancer at the present time. The next was adenovirus. Adenovirus, again, looked very attractive. It could hold a lot. When I did the gene therapy trial in 1999, I was actually ready to launch an adenovirus gene therapy trial. And that's when the unfortunate event, this is a very famous one in the gene therapy world. There's not one translational scientist in gene therapy that hasn't heard of Jesse Gelsinger, so I don't mind using his name. He was an 18-year-old with a relatively mild disease, OTC deficiency. He died 4 days after gene therapy and had an acute respiratory distress syndrome and a systemic immune response. So that kind of left adeno-associated virus as the lone player for AAV for single gene disorders. It's attractive because it has no human disease. And when I got into the field, it was said to have no side effects. it was non-integrating, so that reduced the issue of insertional mutagenesis. And so the first gene therapy we did, and this was the one in 1999 and later again revised when I came to children's, that we would do a limb-girdle dystrophy rather than Duchenne, although certainly Duchenne was our major target at the time. And we chose alpha-sarcoglycan gene deficiency, which is LGMD2D, mainly because it fit into the packaging capacity of AAV. And I hadn't mentioned that, but the packaging capacity actually is 5 kb. And most of the genes that we deal with, for example, the Duchenne gene we'll talk about, is 14 kb. And we try to stuff that into 5 kb, it just doesn't work. And so we chose to do this as a proof of principle for gene delivery. Alpha-sarcoglycan is about 2.5 kb, so it fit into the gene, fit into AAV very nicely. And there you see the cassette on top. And the first gene therapy we did in 1999 was actually with AAV2. By the time I came to children's, there had been really a huge expansion of the AAV serotypes. So we're almost really 100 AAV serotypes. And the most popular one at the time was AAV1. AAV1 was proven in non-human species, mice and in non-human primates, to show it had good gene expression if you injected it locally. It couldn't be delivered systemically, but for proof of principle, as we were at that time, it was ideal. So AAV1 is what we chose. And by this time, we had chose to use what we call an MCK promoter. This is a muscle CK, and CK, that will ring a bell with all of you. So it's muscle specific, and it's human H, and it has the sarcoglycan gene. And the idea was, if we were successful here, we could expand it to all the sarcoglycans, of which there are 4 others in the limb-girdle field. And then we could easily get that into AAV. So here's the story. The way we did this, we injected it actually with ultrasound. And here's ultrasound that is monitoring the gene delivery. And usually I work side by side with one of the interventional radiologists who is guiding the injection. Here's the needle that goes in. Here you can see the needle going into the muscle. And when you inject the gene directly into muscle, here's what you get. You get a good gene expression. But the problem is, obviously, this is proof of principle. You're establishing safety for gene therapy. And that was our goal in the beginning. And so we had excellent gene expression. And in 6 of the first LGMD patients, of the 6 we did, 5 had excellent gene expression like this. This was a double-blind study, so we injected the gene on one side and a control on the other, and there's obvious difference there. These little circles here are where the muscle, these are muscle membrane proteins, and so they bind very clearly, and it was the model for Duchenne dystrophy, very much as we wanted to do. However, when we got to the 6 patients, we learned our first lesson in gene therapy, and that is that we had an immune response to AAV. Not much of this had been talked about before. And so here's what we had on the 6th patient. This is both sides, and neither one of them expressed the gene. So my first impulse was, of course, that there was an error made and the muscle was messed up in the lab, and probably spoke too vigorously about that. But the fact is that there was no gene expression at 6 months. And what we found when we dissected this out more carefully was that we had an overwhelming T cell response at day 2. How could you have a response at day 2 when you just put in the gene and you'd expect a response here over on day 14 or later with immunogenicity? And we had still a very high response in T cells. This is called an Ellie spot response, but the name of that isn't so important. It's that we could dissect out T cells, and we could look at the AAV capsid and see how specific this is. This is immune response. This means that this patient, and this is our big obstacle today, looking at pre-existing immunity to AAV, not only AAV1 in this case, but we're using RH74 now, as we'll talk about, and RH74 can have pre-existing immunity. Pre-existing immunity happens environmentally, can happen to anyone, and it's a sporadic incident that happens. And we're working on how to get around this, but it does preclude gene therapy for that particular patient. And as confirmation of that, here's what we did pre-treatment, and we had, this is the 6 patients we had. Of the 6 patients we had, most of them had gene expression at less than 1 to 50. I'm sorry, AAV immunity at less than 1 to 50, and one had 1 to 1600. This was the patient who didn't respond to therapy, and by day 7 had overwhelming ELISA titers for immunity compared to 1 to 3200, and most of the patients by day 7, he's got over 100,000. So it was clear that he had predisposed. The importance of this goes beyond our own studies, because from that point on, the FDA established that we couldn't do gene therapy unless a patient had less than 1 to 50 titer. And this has been carried forth, and not only for us, but for every gene therapy trial that's been done now in the neuromuscular field and probably beyond that. But it was an important lesson. And the point of this, going through this, is to show you where we learn lessons and how we applied those as we move forward. The next big lesson we learned was immune response to transgene. And this was unheard of because the idea was that patients with Duchenne dystrophy, and now we moved on to Duchenne dystrophy, and we had to use a mini dystrophin gene, and I'll explain more about that in a minute. But here I am working side by side with the interventional radiologist. There's the LED screen. He can see where the needle's going, and we injected. This was the first Duchenne patient we ever did here at Children's. And so, we looked at putting the gene in. And this was a study we did, and thanks to Chris Walker, we learned about this dystrophin immunity in Duchenne dystrophy. And we were taught that this would never be a problem because patients with Duchenne dystrophy had some gene expression. It wasn't blank, wasn't 0. The estimated gene expression for patients with Duchenne dystrophy is about 0.002% of normal protein, but that should be enough to prevent an immune response when we put in the new gene. But what we learned in this was that here's our mini gene down here, and the mini gene or the microgene dystrophin gene means that we have to take out a portion. We take out mostly the middle portion of the gene, these spectrum repeats, and leave some of the spectrum repeats. In this case, we left in 1, 2, and then 22, 23, and 24. There are 24 spectrum repeats. But when we injected the cassette into the patient, it expressed in the patient's deletion of 3 to 17. And guess what? Antibodies and T cells were generated from expression into this area of deletion. So that was a big lesson that we learned, that when we do gene therapy, we can't assume that the patient won't develop an immune response. This is a principle we use to even today, and we're often get asked, why do we exclude patients who have deletions from 3 to 17? The other thing that was the most surprising in this first study that we did was we actually get an immune response from exon skipping. Exon skipping is a spontaneous event that occurs in Duchenne patients. And here's a patient with an exon 50 deletion, but yet he makes protein and it starts in at exon 57. And yet when we did T cell response, we found that the patient had a T cell response that came in at exon 50. And this means that this patient had never seen exon 50 expression before. So this was a new protein for him, and it was an immunity to really a naive protein that we call, these are what we call revertant fibers. And I won't spend too much time on that because of the limited time for this presentation. So those were lessons that we learned early. You must look for patients who had, if you're AAV immunity, pre-existing immunity, must look for patients who had pre-existing immunity to the transgene you're going to express. And then we went on to, there were a number of things we did for that. We've done at least 8, 9 gene therapy trials since I've been here, but I won't talk about all of those, but I want to move on to SMA. So we took all these principles then and moved to what was this first systemic vascular delivery. By this time, the reason we were able to do systemic vascular delivery was in 2006, we started on our, what we thought was going to be a successful road to gene therapy with the lessons that we learned. Steve Allen was the CEO of the hospital at the time, and I went to him and I said that with Reed Clark at my side, who was a very responsible virologist in the gene therapy center, and I said, we can't move this field forward unless we have vector manufacturing. We simply cannot be an academic center and have success without having our own GMP. So this was made possible then by several $1 million that came from NCH that still is making gene therapy possible now at Nationwide Children's. But the lessons that we learned then and the spinal muscular atrophy still stand true. And this is what my point of this presentation is. We learn on every gene therapy trial we've done. There's some success and some learning that goes along with it. Even at this remarkably successful trial, we learned that viral overload to the liver causes a local reaction and the value of the immunosuppressive regimen, even in systemic gene therapy. So just a word about SMA as we moved into this field. SMA, for those of you, I'm not sure who's tuned in here, but the genetics of SMA are always very complicated. The SMN gene, and not SMA gene, it's survival motor neuron gene, is duplicated. One of them, the SMN2 gene, doesn't work well because it does have a mutation, and only a small amount of protein is delivered from SMN2. So you must have SMN1 in order to be normal, and but in SMA, in SMA type 1, there is no SMA, there's no SMN1. It has a mutation that doesn't allow any expression. And then there are varying numbers of copies of SMN2 that exist and allow for some partial protein expression. And depending on the number of SMN2, this represents biallelic ones, which you would expect. So there would be 2 copies of SMN2. And in that case, there's enough protein to maintain life for somewhere around 2 years, but babies can never sit or walk. Then if you have more copies of that spontaneously occurring, you're able to sit, able to walk, and then you can even have an adult variation depending on 3, 4, up to 8 copies of SMN2 that exist. We're talking about SMN1. And in this gene therapy trial, we had SMN1 not expressing and 2 copies of SMN2. And that's still a major principle that we employ today. Although in the current approval for this form of gene therapy, 3 copies of SMN2 then are permitted. And here we have what happens in when we do gene therapy. We take AAV and now deliver the SMN gene now with AAV2. And once we get This is equivalent to now over here replacing SMN1, and then you'll see how we can rescue infants doing that. Now, the other thing that's important about this is that this SMN was delivered with AAV9. Remember, I said the first injections we did with AAV1, we could directly inject them with into muscle. But when we inject AAV1, it can't be delivered systemically. It won't travel through the bloodstream. It definitely won't go into the central nervous system. But because of work in Brian Kaspar's lab with Kevin Faust, they showed that AAV9, that was the first demonstration of that AAV9 would cross the blood-brain barrier. And so it became the delivery tool for SMN and still exists as a delivery tool for especially genes you want to get into the central nervous system. I show this picture, and many of you know this already, and not to dwell on this for too long. SMN, this is an SMA type 1 with severe hypotonia at birth, and the babies often don't get much beyond this. They have bulbar weakness, they don't talk, can't swallow well, have nutritional failure and respiratory failure and death finally. And this is from the Pediatric Neuromuscular Research clinical evaluation of natural history. And what you see here, this is a very nice demonstration of really basically the natural history of SMA. Couple of big points are that 50% are gone by 10 and a half months. Only 8% survival by 20 months, and most are gone by 2 years of age. So that makes the target for gene therapy, I would say, if you're looking at survival, pretty clear. So this was the trial we did with AAV9 at Children's Hospital. This was the SMN clinical gene therapy trial. Here is the gene that we used. And this is with AAV9 delivery. This is the cassette. It has a CMV and chicken beta actin promoter. That was a choice that was made so that there would be widespread gene expression, and indeed there was. And the SMN gene could be delivered to the brain. 15 patients were chosen for this trial, and 2 copies of SMN were selected as the limit of what, because the natural history was so well defined in that group. There were really 2 cohorts. This was common in, or still common in gene therapy trials, to use a dose ascending schedule. Dose ascending means that you go to the FDA and you say, I want to prove that we have safety, so we'll use a gene delivery of a dosing that may not be as effective, but we know that in order to prove safety, we will go at a lower dose. And here are 3 patients, first 3 patients that got it. And then we want to go up to a higher dose that we know from preclinical studies is more effective. And here we can deliver this to the remaining cohort. So 3 versus 12, and that's 15 total patients. Now, the story of prednisolone is very important, that I'll introduce here in a minute, but it stands to reason that this has almost become universal now because of the trial we did here at Children's Hospital. And this was the first baby we did, and I show this because it's intravenous delivery, a little nerve-wracking in the sense that this was the highest dose of virus that had ever been given, and there was concern throughout the gene therapy world. In fact, I got a call from one of the prominent gene therapists in the world not to go ahead with this trial, but we had data from our preclinical toxicity studies that there wouldn't be any adverse effects from the gene delivery that we were using. And I show this because this shows that upon gene delivery, there were very few problems that we had. It was easily delivered, no response from the patient, no disturbance, no distraction, no irritability, and patient tolerated it well. But what we did find was within a very short time, we had a very marked T cell response within a few weeks at the time of that we would expect a T cell response. but accompanying that, we had very high liver enzymes. And that was unheard of. Nobody had reported. Well, there was one report from a hemophilia study, but it was really quite minimal. Here we had, that was an elevation of liver enzymes that was 2 to 3 times elevated. Here we had a 16-fold increase in liver enzymes, pretty frightening actually. And I went to the FDA, talked to our clinical reviewer at the FDA, and we agreed that we would give prednisolone for immunosuppression, and we would start then for all the other patients in this trial, giving this 1 day prior to gene transfer at a dose of 1 milligram per kilogram. We'd maintain it for 30 days. And then in the rest of the low dose cohort, we had our T cell response, but we had no liver enzyme elevation of significance. So we established this clearly as our plan for gene therapy that we maintain today, and we often get asked, why do we do it? This is the reason we do it, to suppress the immune response. So this shows then our survival data that we had. This was a 2-year study that was planned from the beginning. Our first injection was in May of 2014, and the trial ended with complete enrollment by December 2018, when all were treated by 2 years. The low dose cohort all survived. One had some difficulty with respiratory need and for mechanical respiratory support that occurred beyond the 20-month survival. So all of them, in a sense, had survived the clinical trial. In the high dose, 2e to the 14th vector genomes per kilo, all survived easily beyond the 20-month survival. The outcome was death or surrogate use of the ventilator for 16 hours a day for 2 weeks. All were beyond that, although one began to use mechanical ventilation at about 29 months. And just to give you an idea of where we are now, the current age of survival as of the December 2019 cutoff, and all patients were continuing to be followed. The oldest reached 6.2 years in cohort 1, and the oldest reached 5.6 years in cohort 2. And none have lost milestones since that cutoff, and 2 are standing and 2 are walking now. We'll, I think I have a slide to cover that. One of the things that we learned in this trial was that, to use an old adage that I've used for a long time, being a translational clinician most of my life, was hit them hard and hit them early. And this illustrates this. This is the low dose cohort. This is the opposite of hitting them high. This is a patient who had a very low CHOP intend and a very late dosing at 7.9 months. So this is actually the high dose cohort. And it matters how soon you treat the patients. This was actually too late, and we got no clinical improvement when we treated them about 8 months. On the opposite end of the spectrum are patients who were treated at less than 3 months. These patients were treated at 1 month and 2 months, and they achieved CHOP and 10 scores that were in the normal range, and both were able to walk. This is an important principle now that is being carried out here at Children's Hospital by Ann Conley and Megan Waldrop. But if you use low dosing, low CHOP intend, and even if you treat them early, they can achieve improvement, but they don't reach the levels of walking. These patients learn to sit, and all patients in this trial, except this who got the high dose, what Novartis now calls the therapeutic dose, all patients who were treated before 6 months were able to sit. And here is this lone survivor here. but not doing very well in terms of improving clinical milestones. Now, the amazing thing in this trial was that we learned is that patients did develop liver enzyme elevations. And this liver enzyme elevation means that when we deliver the gene, it goes systemically. It goes to every organ in the body, but when it goes to the liver, it gets into the hepatocytes, and as the capsid of the gene is breaking down, it will attract an inflammatory process and develop an immune response. And 4 of the 15 develop liver enzyme elevations. I think we've expanded that now and learned a little bit more about that, but this is something we can suppress with prednisolone, and we use that as a mode of treatment today. Pre-treatment 1 day before, treatment for somewhere now between 30 and 60 days, depending on the clinical trial. And so this gives you an idea of the response to treatment. This patient was dosed at 4 months, and 6 weeks post-gene therapy is able to hold the bottle independently. This is kind of our superstar in the trial. He was treated at 1 month or at 27 days and 4 months post-gene therapy. He's on a course to assume normal milestones for an infant. Here's another patient in the trial who by 6 months post-gene therapy has enough truncal control and head control to show that kind of improvement. And here shows her truncal control. And here she is sitting independently. This is 6 months post-gene therapy. One of the things as a neurologist that's very gratifying is the return of reflexes. And here you can see somewhere I think I can have voice control and also background speech, but that just shows my my gratification for a child who gains reflexes now. And this is our American Ninja Warrior, who is, he's now here about 3 years of age. He's the one that was treated at 1 week, and here he is joining our Center for Gene Therapy and going off to help us with our gene therapy trials and advise us from that point forward. And we definitely appreciate that. And he's one of the heroes in our study. But this one also is the other one who was treated at 2 months of age. She basically achieved mostly normal milestones. She had a little weakness at her ankle dorsiflexors, but not much. And the very gratifying Science Breakthrough of the Year award that we were given in 2017, the time we published the article in the New England Journal. So that gives you an overall perspective. Here's the survival curves and the response depending on time of delivery. So we took all of these lessons. Now we learned about immune response. We learned about how to suppress the immune response. We learned about pre-existing immunity to both virus and not only virus, but also transgene, things we had totally non-suspected. And we have put this application now to the DMD gene therapy trial, which we're heavily invested in now. In fact, we treated, in this trial now, we've treated 40 patients, and which is probably the largest gene therapy trial that's ever been done anywhere in the world. So this is an important slide because here I mentioned, here's the cassette. Now we have used a more sophisticated promoter for this gene therapy trial. Remember, I showed you in the first gene therapy, we used an MCK promoter. Now we use an MHCK7 promoter. The MH is indicative of our ability to express the gene in the heart. So we get cardiac and skeletal muscle gene expression. Introns, I didn't elaborate on this before, but it promotes more rapid gene expression. And now we use what we call a micro or mini gene. And this micro or mini gene has to be developed from virtually hundreds of preclinical studies from the full, here's the full gene, the full Duchenne gene. And we have the full Duchenne gene means that there are actually 79 exons. A huge part of this are the internal spectrum repeats. This is actually what the protein looks like. It has 4 hinges, a cysteine rich domain, and a CT termination. And we have to remove some of the spectrum repeats and some of the hinges to make this smaller and then prove that it will still work. And in this case, we remove of the 24 spectrum repeats, we maintain 4. This is the first 3 right here, and the final spectrum repeat, and we use hinges 1 and 2 and 4, and remove spectrum hinge number 3. There's a rationale for doing this because hinge 1 and 2 then maintain their morphometry with the other spectrum repeats, and this one logically can be deleted without much cost to relationship to other spectrum repeats of the gene. And it's the cysteine rich domain that allows for expression and a ligand to other proteins in the cell. So here's the final gene that we use, and now we deliver it with a gene AAV RH74, and we're often asked, why do we use RH74? Well, the reason is because of proprietary reasons. AAV RH74 was isolated here by Phil Johnson and Reed Clark, and so it has some proprietary belonging to Children's Hospital, and we can use this with fewer issues related to other AAV serotypes. The gene expression we had here was basically overwhelming. We inject this in systemically. That means we inject it into a systemic vein into the forearm muscle, and in this case we looked at gene expression at 3 months, and we have very good gene expression that is extremely robust, that reached over 80%. This kind of a gene expression has never been seen before in any gene therapy trial, and that's still true today. And we have 96% intensity. These are this was a trial that we did where we have pre-treatment biopsies versus post-treatment biopsies, and it's very clear that we're reaching almost normal levels. And here we have expression in the sarcoglycans. If the gene is working properly and the protein is expressed properly, it will form ligands with other proteins in the cell, and the sarcoglycans form what we call the dystrophin-associated protein complex. And so we have very good gene expression there. And I like to show this one because this is almost unheard of. In the 4th patient we used, we have 96% gene expression. So here you can now look at what kind of results we get. This is with looking at CK results. This we see at the 1 year time point, we see a very significant drop in all 4 patients. The results of this study will be published actually June 15th in JAMA Neurology. And we also get in the North Star ambulatory assessment, we get improvement in all 4 patients. And this is the degree of improvement we have in these 4 patients. And more importantly, here's a look at the patients. This again I show because it means this is right after the gene delivery. There's absolutely no toxic effect. Here you get some insight into gene delivery. We put IVs in both hands, and we deliver the gene in one of the hands here. Here you can actually see the connection here. We keep one IV open on the other side in case this one is stopped. We inject the gene over an hour and 15 minutes to an hour and a half, and we get no toxicity. And here we see what happens. This is at 2 months post gene therapy. We get very good beginning to see improvement in motor function. 6 months post gene therapy, see a child who's running clearly. This one I like to show because this is 2 days post gene therapy, walking up steps one at a time. And here the patient is 2 months post gene therapy and having good gene delivery. And what it also shows is that with the gene response actually occurs pretty quickly in these diseases. We're beginning to see improvement by 30 to 60 days, and that's very encouraging. This one I like to show because here he's going up the steps using reciprocal stair climbing and holding in something in his arms so he cannot use. This one I think is very informative because this is typical patient who's not treated, having a full Gowers, and on this side you could see the patient getting up very quickly. And when we look, there it is again, you can see that very nice distinction. Here's one of my favorite ones at 18 months post gene therapy, getting up without any problem. And now we see that what the side effect profile is. In this trial, in the first trial, this was open label trial, non-controlled. We had 3 subjects who had elevated liver enzymes within the first 2 weeks, and patient 4 had increased liver enzymes following the pred taper. Once we tapered the pred, he developed liver enzymes from post-prednisone inflammatory process. So you have to be careful, and we sometimes have to, if we see this, we'll often give a dose of IV steroids to suppress a later increase in liver enzymes. No other clinically significant laboratory findings. Sometimes we see minimally elevated bilirubin, and that's one thing we have to react to. And so in this trial, which is very common, this is another thing we've learned. This had never been seen before. It's only with this high dosing that we see patients, and this is beginning, we've seen this now in over 50% of the patients, maybe even higher numbers. We see patients who will begin vomiting on about the 3rd day. They can vomit up to 6 weeks, maybe longer, and they'll have an episode in the morning when they get up, vomit transiently, and then have no problem the rest of the day. The cause for this vomiting is unclear. It's not necessarily correlated with liver enzyme elevation or with steroid administration. So whether the gene is irritating the epithelium of the GI tract or going to the chemoreceptor trigger zone in the brain is not really clear, but this is a very consistent response. So the 2 things we see are increased liver enzymes and this transient nausea and vomiting, neither of which have much impact on the outcome of the study. So overall, we have had very good response, but we've learned this in a stepwise fashion over basically, I'll say, since I've been here at Children's for the past 16 years, with a little bit of information starting and a little bit of, I guess, nerve in starting the gene therapy as early as 1999. So none of this could be done without the team here at NCH, and I have lost some of the people who began here. Louise Rodino-Claypack was one person who I miss. She's now full-time at Sarepta. Zarisha Hank, she doesn't like me to say that ever, but we've worked together for over 40 years. She was the 2nd fellow I've ever had. Samuel Zaidi was another very important fellow. Kelly Lehman has been absolutely essential to where our trials are, and we've recently had another nurse practitioner. We have the CRS coordinators, Jordan and Christina. People in the like Richard Shell and Linda Kripe have been very helpful in helping us negotiate our way through any cardiac or pulmonary problems. The physical therapists are beyond explanation in terms of what they've done. And I also like to acknowledge Brian Arthur and Kevin Faust for their contribution to the SMA gene therapy. So I don't know where I am in terms of time, but I'll open this up for further discussion. And I think Ann Conley was going to negotiate the questions here. So thank you very much.
Well, first of all, thank you. That is really, really clear and spectacular. And for somebody who watched from the outside in, it's really, really amazing to see it all unfold. We do actually have some questions from the audience. And the first one, the first question is, do some patients need immunosuppression for longer than the 60 days? And then a second question from the same person is, children with Duchenne are treated with corticosteroids routinely, and they want to know what % were able to get off systemic immunosuppression eventually. So kind of a two-part steroid question.
Well, very good questions. And in most cases, 60 days is probably the limit of what we need for immunosuppression. At times, there are times we've actually had to use the steroids for as long as 3 months. So, and we've had a post tapering elevation of liver enzymes that we've seen after withdrawal after even the first 60 days. So we've had to reinitiate that. And we kind of have basically it's a gut feeling. If we see the liver enzymes continuing to rise when we use even though we've used it prophylactically, if they're continuing to rise, and the exact number is more in the gut than it is on paper, but let's say if the GGT, and I didn't really elaborate on this, but if the GGT is elevated and continues to go up at about 300, we'll give an IV dose of methylprednisolone to suppress that. So now that I brought that up, why GGT? In the Duchenne patients, we use GGT to monitor liver enzymes because AST and ALT are naturally from the muscle and from liver. And so we can't clearly distinguish where the ALT and AST are coming from. And so we use GGT to monitor. There are flaws in that, since GGT is more indicative of obstructive liver disease, but that's our best guidance, and it does work pretty well. The other question about the routine use of steroids is clear, and we do, I wish we could do what the question directed. Could we get patients off steroids? All patients are on steroids with Duchenne dystrophy. That's actually a criteria for enrollment. They have to be on steroids for at least 12 weeks on a maintenance dose before they can be enrolled in the study. So far, the best we've seen is as patients are improving, we in general have let the steroid dosing drift down and not control it for weight. So it's no longer milligram per kilogram. So in a sense, it's lowering the dose, but we don't have good insight right now as to whether we can get patients completely off steroids. I only wish that we can, and that's one of the goals that I have.
Thank you. Alex Kemper, there's a couple of questions that have sort of been answered regarding newborn screening, but here's one from Alex Kemper to you. He asks, is there any role for nusinersen in the treatment of SMA when gene therapy is available?
I want to comment on the newborn screening, even though it may have been addressed because it's so critical. the newborn screening that there are 23 states now as a result, pretty much as a result of this study that are using newborn screening now, or added newborn screening to the RUSP profile for SMA. And this is huge, because what we showed in this trial is that if we can treat the patients early, we can completely reverse the disease. So I'm reluctant to use the words, and I'd never do it in a national meeting, but basically with this regimen, we can cure the babies if we treat them very early. So in Ohio now, we have newborn screening for SMA, and a lot of those newborn screens, because of the reputation we have now at Children's, come to Children's, and Ann Conley and Megan Waldrop are critical in receiving those patients from the newborn screening. And the ones that have been treated very early also will have complete reversal of disease. So now on to the question of dual treatment. And we have for our patient trial, we have in the low dose patients, that's a 3 at low dose, 6.70 to the 13th. We have all those patients are on combinational therapy, or got gene therapy, and now are on nusinersen. And I don't think it's made a heck of a lot of difference. For the high dose patients, or the therapeutic dose, we have 4 of the patients who are now on nusinersen. And I don't think, again, it's made much of a difference, and Anne might want to comment on that. She's following a number of those patients who are on combinational therapy.
Yeah, I certainly agree with that. And I think that add-on therapies should be studied in a research setting. But there's another question from Pittsburgh. And the question is, do you anticipate children with SMA or DMD will need repeat injections as they grow in size?
Well, part of the reason I didn't dwell on it, but we have long-term follow-up now in the SMA study, and basically every patient in the high dose or therapeutic dose in long-term follow-up has continued to improve. And I said that the oldest we have now, remember, these patients were treated, except for one patient. I probably didn't emphasize this enough in comparing the low dose, but the oldest one at 7.9 months or 8 months never improved. But all the other patients all the other patients on the therapeutic dose have continued to gain milestones. And the oldest now in the therapeutic dose is over 5 years of age, continuing to improve. And we had 2 walking, and now we have in that trial 2 standing. The answer to your question is we don't know. We don't know whether they'll require redosing. We're trying to be poised to look at that, and by planning a plasmapheresis trial for patients who developed high antibody levels or have pre-existing antibody levels. But I think, being fair, I don't know. But my belief is that there's every reason to believe that when adeno-associated virus takes up shop in the neuron, for example, and it forms, the gene is delivered and basically establishes its independent role, and really analogous to an independent chromosome in the neuron. And if it rescues the neuron, I see no reason that we would have those initial concerns I said. Unlikely to have promoter shut off after 5 years after the gene has been delivered, and some of the original, and the toxicity is no longer an issue after the gene has been delivered and the kids are that old. So I think it's a lifetime treatment, but that remains to be seen, and I'm an eternal optimist. So that's where I stand. So
Well, that's a great last statement to end on. And thanks, everybody. There were more than 100 folks on this. And I thank you, Dr. Mendell, very, very much for a spectacular presentation.
thank you.
Thank you.